Usually when we talk about a medical diagnosis, there is an expectation of just absolute mechanical precision.
Right, yeah.
Like if you were listening to this and you've ever broken a bone, you know the routine. The doctor puts the x-ray up on the screen, points to that jagged white line and says, well, there's the break.
Yeah, it's simple engineering.
Exactly.
It's entirely binary. Like the bone is either broken or it isn't. The structure is clean and, the solution is pretty straightforward.
But the moment you step into the world of the human heart, and specifically how the human heart builds itself before we are even born, that expectation of simple engineering just goes right out the window.
Oh, absolutely.
We so often think of the heart as just a basic pump, right? Like four chambers, a few valves, some plumbing attached. But the sources we are looking at today reveal the developing heart as something, well, much more complex.
Yeah, it really is.
It's essentially an intricate, high-stakes origami project.
An origami project where,
Right.
honestly, a single fold in the wrong direction, like even a fraction of a millimeter off, completely rewires human physiology.
Yeah.
And the text we're analyzing today gives us the exact blueprints of that origami.
Welcome to today's deep dive. Our mission today, for you listening, is to decode a highly detailed medical text on congenital heart disease, or CHD.
Right.
We're taking what are essentially dense clinical anatomical notes
Mm-hmm.
and transforming them into a journey through the human heart's developmental blueprints.
Which is fascinating.
We are going to cover everything. How genetic lotteries and incredible fetal bypass systems can actually mask major heart defects.
Yeah.
We'll explore the bizarre ways the heart can be miswired, and we will walk through the exact step-by-step emergency protocols used to save a child who's turning blue in a cyanotic crisis.
It is a vast landscape, truly. But understanding these defects isn't just some exercise in memorizing anatomy.
Right.
It's really about understanding how resilient and simultaneously how incredibly fragile the human circulatory system truly is.
So let's start at the foundation, the blueprint itself. The text opens by outlining the principles of inheritance for congenital heart disease.
Mm-hmm.
And it establishes early on that most forms of CHD have a multifactorial etiology.
Right, multifactorial.
Which means if you're trying to figure out why a baby is born with a heart defect, you aren't usually looking for one single culprit.
No, you're not. And that is a crucial distinction. It's not like flipping a single genetic switch,
Like you carry gene X, you get the disease.
Exactly. Multifactorial means there's a threshold. A developing fetus might have some underlying genetic predisposition, like a few vulnerabilities in their DNA.
Okay.
But it takes a combination of those genes interacting with environmental factors to actually cross that threshold.
What kind of environmental factor?
Well, it could be anything from maternal nutrition to viral infections encountered during pregnancy.
Oh, wow.
Yeah, only when that combined weight crosses the threshold does the anatomical defect actually manifest.
And the numbers the text provides give us a really clear picture of how often that threshold is actually crossed.
Let's do.
The baseline frequency of congenital heart disease in the general population is 0.7 per 100 live births.
Right.
Or, to make it easier to visualize for you listening, 7 out of every 1,000 live births. So if there is absolutely no history of CHD in your family, your risk as a couple of having a child with a heart defect is less than 1%.
But watch what happens to the math when family history is introduced.
Yeah, this part was crazy.
If a first-degree relative has a congenital heart defect, meaning a parent or a sibling, that risk for the new child jumps significantly.
Right.
It goes up to between 2 and 5%. And out of the total newborn infants who do have a defect, about 2 to 3 out of every 1,000 will be symptomatic in the very first year of their lives.
Now, here's a detail from the text that completely stopped me in my tracks.
The gender predilection.
Yes, it talks about recurrence risk, but specifically how it relates to the gender of the parent who has the disease.
Yeah.
The text states that if a specific heart defect is more common in one gender, the risk to the child is mathematically higher if the defect is inherited from the parent of the less commonly affected gender.
That's wild.
I had to read that 3 times. Wait, let me unpack this. Why does the gender of the affected parent change the statistical risk for the child if we were talking about the exact same structural defect?
It sounds like an absolute paradox, but if we connect this back to the idea of the multifactorial threshold we just talked about, the math actually aligns beautifully.
Okay, walk me through it.
So the text uses aortic stenosis as the prime example. This is a narrowing of the aortic valve, and it is a defect that is significantly more common in males than in females.
Okay, so a male fetus is statistically more likely to develop it.
Precisely. Because males develop it more frequently, it implies that the male biology has a lower genetic threshold for aortic stenosis.
Got it.
It takes fewer genetic hits or fewer environmental triggers for a male to manifest the disease. Females, by contrast, possess a natural biological resistance to this specific defect.
So their threshold is much higher.
Exactly. Therefore, for a female, like a mother, to have actually developed aortic stenosis herself, she must have been dealt a massive concentration of those underlying genetic risk factors.
Oh, to overcome her natural biological resistance.
Exactly, that's the only way she gets it.
So she is essentially carrying a much heavier hidden genetic backpack of the disease traits simply because she managed to develop it despite being female.
That is the exact mechanism. So when she reproduces, she has a much larger, denser pool of those risk-conferring genes to pass on to her child.
Compared to a father who has the disease.
Right, because the father didn't need as many bad genes to cross his lower threshold. Thus, the risk to the child spikes if the mother has it.
But it's just brilliant.
It's a real-world demonstration of how threshold genetics actually operate.
It totally reframes the whole concept of inheritance for me. We aren't just dealing with broken plumbing, we are dealing with a highly calibrated genetic lottery.
We really are.
But speaking of the plumbing, the text highlights a fascinating phenomenon about fetal circulation. It notes that massive, sometimes fatal congenital heart diseases are perfectly well tolerated during fetal life.
They are. The fetus develops normally.
And that is because the fetus operates on a parallel circulation system. I was trying to picture this, and I keep coming back to a construction analogy, like a plumbing bypass.
Okay, I like that. Walk me through the mechanics of your bypass.
Imagine you were building a house, right?
Yeah.
You've got the sinks, the showers, the internal pipes, they're all installed. But the main water line from the city isn't hooked up yet because the house just isn't finished.
Right.
So to test the internal pipes, the construction crew sets up a temporary bypass system, just a separate pump and a parallel hose moving water through the house, completely ignoring the main municipal supply line.
I see where you're going.
In the womb, the baby isn't using its lungs to breathe. The mother's placenta is providing all the oxygen.
Right.
So the baby's heart has these built-in temporary bypass hoses, specifically the ductus arteriosus and the foramen ovale. And they intentionally route the blood completely around the lungs.
It is a devastatingly efficient system for a fetus. Because the placenta is doing the respiratory work, the fetal heart isn't required to send blood to the lungs for oxygenation.
Right.
Because of those specific bypasses you mentioned, a fetus could have a catastrophic structural defect. I mean, they could be missing a valve entirely.
Oh.
They could have a gaping hole between their ventricles or have their main arteries wired to the wrong chambers. And yet, they will develop perfectly fine in the womb.
Because the parallel circulation perfectly masks the architectural failure.
Exactly. It completely hides it.
But the illusion shatters the moment they're born. The baby is delivered. They take that first massive gasp of air. The umbilical cord is clamped. And suddenly, boom, the construction crew yanks out the temporary bypass hoses and turns on the high-pressure city water.
Yeah. The hemodynamics, the physical pressures of the blood flow, they change in an instant. The lungs inflate, the resistance in the pulmonary vessels drops drastically, and blood rushes in.
And that is the exact moment the architectural flaws are violently exposed.
Right. The text points out that these physiological changes have an increasing impact on how the cardiac defect manifests. For instance, the patent ductus arteriosus, or PDA.
The ductus is one of those bypass hoses.
Exactly. It's supposed to organically clamp shut due to the rush of oxygen. But if it remains open beyond 3 to 4 weeks after birth, it transitions from a normal fetal structure to a fully established pathological PDA.
And the heart is also a moving target.
Right.
It's growing rapidly. The text mentions that the relative significance of a cardiac lesion can actually shift with growth.
It can.
Like some ventricular septal defects, specifically the muscular ones, can actually heal themselves.
Yeah, as the heart muscle hypertrophies and grows, it can naturally pinch the hole shut.
which means cardiologists aren't just diagnosing static structures.
No, they are diagnosing dynamic, evolving systems. And to do that accurately, they needed a universal language.
Right.
Historically, congenital heart defects were given confusing, eponymous names based on the doctors who discovered them.
Which told you absolutely nothing about the actual anatomy.
Exactly. So the medical community developed a completely new way of describing the heart, which the text calls the sequential segmental approach, or the SSA.
I think of the SSA as like the grammar of the heart. If you want to understand the diseases, you have to learn the language first.
That's a great way to put it.
It's a highly descriptive approach based purely on following the physical flow of blood, like tracking a package on a conveyor belt.
Right.
You start from the venous return entering the heart, track it into the atria, through the atrioventricular valves, into the ventricles, and finally out through the semilunar valves of the great vessels, the aorta, and the pulmonary trunk.
And to make this tracking system work, the SSA relies on a very specific, standardized nomenclature.
Yeah, let's unpack those core terms the text requires us to know. First is connection.
Right, connection.
This simply refers to the sequence of the anatomy. Does chamber A connect to chamber B?
Simple enough.
Next, we have concordance and discordance. If you're listening, think of concordance as harmony. It describes a normal relationship.
Right, so the right atrium connects to the right ventricle, and the right ventricle connects to the pulmonary artery. Everything matches up as the blueprint intended.
Exactly. Discordance is the opposite. It describes abnormal relationships. But the text uses a very specific phrase here that definitely needs translation.
Okay.
It says discordance is when, for example, the right atrium leads into a, quote, morphologic left ventricle. What does morphologic mean in this context?
Oh, that is a vital distinction in the SSA. A left ventricle isn't just called the left ventricle because it happens to sit on the left side of the chest.
It's not about location.
No, it has a specific intrinsic structural identity, a morphology. A true left ventricle has very thick muscular walls designed for high pressure. It has a finely textured inner lining, and it's attached to a mitral valve.
Okay, so it has specific features.
Yes. So in severe congenital defects, the developing heart might build a perfectly structured left ventricle, but mistakenly position it on the right side of the heart, connecting it to the right atrium.
Oh, wow.
The SSA forces the diagnostician to identify the chamber by what it actually is structurally, not merely where it sits. So if the right atrium connects to a chamber that is built like a left ventricle, that is an atrioventricular discordance.
It's like walking into a house, opening a door on the right side of the hallway where the bathroom should be, and finding a fully plumbed, fully furnished kitchen.
Exactly.
It's a kitchen, regardless of where it was placed. That makes perfect sense. Moving down the grammar list, we have imperforate connections.
Right.
This is where a valve might be physically present, but it is sealed shut. It's a door that won't open, completely blocking blood flow.
Yeah.
And then there is commitment. This describes abnormalities of flow through valves into the ventricles or great vessels.
Commitment is a fascinating mechanical concept. The text uses Tetralogy of Fallot, or TOF, as its primary example here.
Okay.
In a heart with TOF, the atria, valves, and ventricles are positioned normally. They're concordant.
Right.
But there's a massive hole in the wall between the two ventricles, and the aorta, the massive pipe that is supposed to pull freshly oxygenated blood exclusively from the left ventricle, is physically shifted over.
It moved.
Yeah, it sits directly above that hole. And because of its shifted position, it receives blood flow from both the right ventricle and the left ventricle simultaneously.
Oh, wow.
So in the language of the SSA, we say the aorta is doubly committed.
Doubly committed. That is a perfect architectural description.
Yeah.
It's a set of double doors that open into two completely different rooms at the exact same time.
Exactly.
And if the anatomy is so mangled that you can't even tell what room you are in, the SSA uses the term ambiguous. The text notes this is used when a ventricle cannot be precisely identified. Imagine a heart with only one massive pumping chamber, and both the tricuspid and mitral valves empty into it.
Yeah, you simply cannot tell if the body was trying to build a right or left ventricle. It's just an ambiguous room.
And lastly, inlet refers to the pathway of blood flowing into the ventricle, while outlet is the pathway flowing out.
So with those terms, you can describe the internal wiring of any heart. But the text states that the SSA also demands we look at the very foundation of the organs, something called the atrial cetus.
Right, cetus meaning position or arrangement. The atria are the two upper receiving chambers of the heart.
Yeah.
And the text is super clear about this. In complex congenital heart diseases, the most difficult cases to unravel are the ones involving abnormalities of the atrial cetus.
They really are.
There are 4 possible arrangements for the atria. First is the baseline normal. The right atrium is on the right, the left atrium is on the left. This is called cetus solitis.
Solitis, right.
Then you have the exact mirror image. Everything is flipped. The right atrium is on the left and the left is on the right. This is called cetus inversus.
But then the text introduces the isomerism types. Isomerism means structural symmetry, and this is where the biological blueprint truly glitches.
Yeah, this part is wild.
Right. Isomerism is a condition where the heart develops bilateral right atria. The fetus essentially grew 2 right atria and completely failed to build a left atrium.
Wow.
And the text provides a massive clinical clue here, right? Isomerism is usually associated with asplenia syndrome. The patient is born without a spleen.
Now wait, why would having 2 right atria mean you don't have a spleen? How are the heart and the spleen connected in the blueprint?
It comes down to how embryos develop left-right asymmetry. Very early in gestation, the cluster of cells has to decide what organs belong on the left side of the body and what belongs on the right.
Yep.
The right atrium is biologically a right-sided structure. The spleen, however, is a left-sided structure. If the embryo experiences a catastrophic signaling error that essentially broadcasts the message, make everything on both sides of the body a right-sided structure, the heart dutifully develops 2 right atria.
Oh, I see.
And because the abdomen is also following that flawed right side only instruction, it fails to develop any left-sided organs. Therefore, no spleen is ever formed, asplenia.
So the heart defect is actually just one visible symptom of a total body mirroring error.
Exactly.
That is incredible, and that perfectly explains the next type, left isomerism. This is bilateral left atria, so the heart grows 2 left atria.
Right.
And following that exact same embryonic logic, the text notes this is associated with polysplenia syndrome.
Yeah.
The body is heavily prioritizing left-sided organ development, so it accidentally builds multiple small fragmented spleens in the abdomen.
Exactly. To synthesize all this grammar, the text provides 2 critical tables that categorize these diseases, assuming the chambers and valves are in their normal sequence.
Right, table 1 and table 2.
Table I covers shunting predominant lesions like holes in the heart walls. PDA, VSD, ASD.
Got it.
It also covers obstructive lesions where connections are absent, like tricuspid or mitral atresia, or where major vessels are pinched, like coarctation of the aorta. And it includes anomalous valve positions. Have you come across Ebstein's anomaly in your reading?
Yeah, it's mentioned in the text, but the mechanics aren't deeply explained. What exactly is Ebstein's anomaly?
So, in a normal heart, the tricuspid valve sits neatly between the right atrium and the right ventricle.
Right.
In Ebstein's anomaly, the leaflets of that valve fail to attach at the proper junction. They slip drastically down into the right ventricle itself.
Oh, wow.
Yeah, it functionally atrializes a large portion of the ventricle, making the actual pumping chamber dangerously small and weak, while the atrium becomes massively engorged.
That paints a really vivid picture.
Yeah.
Table 2 then deals with anomalies of relationships. This includes atria-to-ventricle anomalies, like a double inlet right ventricle where both top chambers empty into the right pump.
Right.
It also covers anomalies between the ventricles and the great arteries, which includes Tetralogy of Fallot, double outlet right ventricle, truncus arteriosus, and transposition of the great arteries.
Right. So we have established the vocabulary. We know the grammar. Now, the text shifts from the abstract blueprint to the physical consequences. It's time to apply this grammar to specific structural failures.
Starting with what we can call the overflow problem.
Yes.
This brings us to the section on acyanotic lesions. Acyanotic meaning these patients do not typically turn blue. They are successfully oxygenating their blood, but the mechanics of the pump are terribly inefficient.
Right.
These lesions are characterized by left-to-right shunts.
Let's clearly define the hemodynamics of a left-to-right shunt.
Please.
The left side of the heart is the high-pressure system.
Ah.
It has to pump blood to the entire body. The right side is the low-pressure system. It only has to pump blood next door to the lungs. If there is a hole between the 2 sides, fluid dynamics dictate that blood will always flow from high pressure to low pressure. So blood crosses from the left side back over to the right side.
And the result of that is highly oxygenated blood, which was just about to be sent out to the body, gets dumped back into the right side and sent right back to the lungs again.
Yeah, exactly.
The heart is recirculating the exact same blood over and over. It is a massive waste of energy. The text expresses the magnitude of this wasted flow using a specific ratio. QP over Qs.
Right, QP over Qs. Q represents the total volume of pulmonary blood flow, so the amount of blood hitting the lungs. Qs represents the systemic blood flow, the amount of blood actually making it out to the body.
Okay.
In a perfectly functioning heart, the amount of blood going to the lungs equals the amount going to the body. So Q divided by Qs equals 1.
But in a left-to-right shunt, the lungs are getting their normal share of blood from the body, plus the extra blood sneaking through the hole from the left side.
Right.
So QP is larger than Qs. The ratio is greater than 1. The text gives us clear clinical parameters here.
Yeah.
If the ratio is between 1 and 1.5, it is considered a small shunt. Moderate is 1.5 to 2, and a large shunt is anything greater than 2. If a child has a ratio of 2, it means their lungs are being flooded with twice as much blood as the rest of their body.
And this leads directly to the core mechanical issue. Volume overload.
Volume overload.
If you continually pump too much water into a closed pipe system, the pipes and the reservoirs they drain into are going to physically stretch, dilate, and eventually fail.
Yeah.
And the text is incredibly precise about which specific chambers get overloaded depending on the location of the defect.
Let's start with atrial septal defects, or ASDs.
Yeah.
This is a hole in the wall between the two upper receiving chambers.
Right.
The incidence is 1 in 5,000 live births, making up roughly 6 to 10% of all congenital cardiac defects. Interestingly, the text notes it has a 2.1 female preponderance, meaning girls are twice as likely to have it.
Now, if you are listening, try to visualize the overload pathway here. The high-pressure left atrium pushes blood through the hole into the lower-pressure right atrium.
Okay.
So the right atrium immediately gets overloaded and stretches. That extra volume then falls down through the tricuspid valve into the right ventricle, so the right ventricle gets overloaded.
Right.
It then gets pumped out into the pulmonary artery, so they get overloaded. But notice what is perfectly safe. The left ventricle.
Wait, really?
Yeah, the extra blood escapes the left atrium before it ever drops into the main pumping chamber. The left ventricle is entirely spared from the volume overload.
Wow, okay. The text breaks ASDs down into 4 distinct anatomical types based on exactly where the hole is located.
Right.
The ostium secundum is the most common type, located right in the middle of the septal wall. Then there is the ostium primum, located lower down.
And the text explicitly links the ostium primum type to abnormalities of the atrioventricular valves, like mitral regurgitation, because those structures develop from the same embryonic tissue.
That makes sense.
Yeah.
Third is the sinus venous defect, located high up near where the superior vena cava enters. And the rarest type is the unroofed coronary sinus.
Clinically, ASDs can be dangerously deceptive. Most are completely asymptomatic in childhood. The text notes that less than 10% will present with congestive cardiac failure or poor growth.
That's wild.
But a careful physical examination reveals the mechanical strain. You might feel a right parasternal heave, literally feeling the chest wall lift slightly because that right ventricle is working so hard and has grown so enlarged.
And the acoustic signatures, the murmurs, are fascinating, though they definitely require some translations.
They do.
The text states that an ASD produces a wide and fixed splitting of the second heart sound. Let's translate that.
Okay, sure.
Usually a heartbeat sounds like lub-dub. The dub is the sound of the aortic and pulmonary valves snapping shut. Normally they shut at almost the exact same time.
Right.
But in an ASD, the right ventricle has so much extra blood to pump out to the lungs that it takes a fraction of a second longer to empty. So the pulmonary valve snaps shut slightly late. The dub splits into 2 distinct sounds.
What the dub?
Exactly. And it is fixed because unlike a normal heart where that split might change slightly when you breathe in and out, the massive volume overload in an ASD means the split is permanent, regardless of respiration.
That is a perfect explanation of the mechanics. You also might hear an ejection systolic murmur loudest at the upper left sternal edge.
Okay.
But the text makes a crucial point. That murmur is not the sound of blood flowing through the hole in the atrium.
It's not.
No, the pressure difference between the atria is too low to make a sound. The murmur you hear is actually the sound of that massive volume of extra blood rushing violently through the pulmonary valve.
Oh, wow.
If the shunt is massive, you might even hear a mid-diastolic murmur, which is the sound of all that extra blood tumbling through the tricuspid valve.
The text also mentions an ECG finding, a classic RSR prime pattern in leads V1 and V2. If you picture an ECG readout, an RSR prime looks like a capital letter M.
Right.
The electrical signal that tells the ventricles to squeeze is physically tripping and taking longer to travel through the right ventricle because the muscle wall has been stretched so wide by the extra fluid.
Exactly. The electrical pathway is physically lengthened. On a chest X-ray for a large shunt, you will see cardiomegaly, an enlarged heart, along with increased pulmonary vascular markings, meaning the blood vessels in the lungs look thick and engorged on the film.
So how do you fix an ASD?
Well, it requires either surgical closure with a synthetic patch or a device closure using a catheter threaded up through the groin. The usual age for elective closure is between 2 to 4 years.
Okay.
However, if an infant presents with heart failure, indicating a massive, poorly tolerated shunt, it must be repaired in infancy. The text also notes that except for the secundum type, ASDs usually do not close spontaneously. You have to intervene.
And what happens if you don't? Like, what if it goes undiagnosed?
This is where the silent hole becomes lethal. Over years, the right atrium enlarges, which stretches the electrical nodes and leads to dangerous arrhythmias.
Oh, man.
But worse, if the shunt persists into the second decade of life, the sheer pressure of all that extra blood pounding into the delicate pulmonary blood vessels causes permanent, irreversible scarring.
The Eisenmenger syndrome.
Yes. The vessels stiffen, the resistance in the lungs gets so incredibly high that eventually the pressure on the right side of the heart becomes higher than the left. And suddenly, fluid dynamics reverse.
The shunt flips.
Exactly. Deoxygenated blue blood starts flowing from the right atrium across the hole into the left side, completely bypassing the lungs. The patient begins to turn blue. The text calls this Eisenmenger syndrome, and once it happens, it is irreversible and catastrophic.
From a silent, invisible hole to total circulatory collapse decades later.
Yeah.
Let's move down the heart to the lower chambers. Ventricular septal defects, or VSDs.
Right, VSDs.
This is a hole in the thick muscular wall between the main pumping chambers. The text notes the global incidence is 1.5 to 3.5 per 1,000 live births, constituting about 20% of all congenital heart disease globally.
Yeah.
But here is where the text gives us a really striking data point. Locally, for the author's region, it makes up 40% of all CHD. And in the city of Uyo specifically, it is 47%. Almost half of all congenital heart defects in that specific region are VSDs.
And that geographical spike is a profound clinical data point. It circles all the way back to the multifactorial etiology we discussed at the start.
Also,
When you see a specific defect jump from a 20% global average to nearly 50% in one specific city, you are seeing the direct impact of localized environmental triggers, specific nutritional deficiencies, or isolated genetic bottlenecks.
right.
They interact to dramatically lower the threshold for that specific anatomical failure.
Unlike ASDs, there's no gender predominance for VSDs. The text outlines 4 types. First is the perimembranous type, located in the outflow tract of the left ventricle. The text notes a fascinating mechanical quirk about this one. It can actually close spontaneously. Sometimes the septal leaflet of the nearby tricuspid valve sort of gets sucked over the hole and plasters it shut.
It's amazing. Second is the supracrystal VSD, located higher up, right below the aortic valve cusp, which can sometimes cause that cusp to prolapse or sag into the hole.
Third is the inlet VSD, located in the posterior septum beneath the tricuspid valve. Structurally, this type lacks the muscle tissue required to grow and pinch off, so it never closes spontaneously.
Never. And fourth is the muscular VSD, located lower down in the thick trabeculated muscle. Because it is surrounded by sheer muscle, this type has the highest rate of spontaneous closure as the infant grows and the muscle hypertrophies.
Now let's look at the overload mechanics for a VSD. Because if you were visualizing the flow, it is fundamentally different from an ASD.
It is entirely different. In a VSD, the hole is between the strong lower ventricles. When the massive left ventricle forcefully contracts, it shoots blood right through that hole, directly into the pulmonary artery. So the pulmonary artery gets immediately overloaded. That massive volume of blood goes to the lungs, returns to the left atrium, overloading it. It then drops into the left ventricle, overloading that.
Right.
But notice the paradox. The right ventricle itself is largely spared from volume overload.
Wait, how is the right ventricle spared if the hole is right there in this wall?
Because of timing. The right and left ventricles contract at the exact same millisecond.
Oh, right.
During systole, the squeeze, the pressure in both chambers is spiking. The blood from the left ventricle shoots through the hole, but because the right ventricle is simultaneously squeezing, that extra blood doesn't hang around to stretch the chamber. It is instantly rocketed straight up the pulmonary pipe.
That is a brilliant mechanical distinction. Clinically, small VSDs are usually caught by a very loud murmur. The text describes it as a pansystolic murmur maximal at the lower left sternal edge.
Yeah, pansystolic.
Pan means all, so throughout the entire squeeze of the heart, you hear a continuous, harsh whoosh of blood jetting through that tiny, restrictive hole under immense pressure. For paramembranous and supercrystal types, that murmur radiates upward.
Small VSDs might just have a loud murmur, but large, unrestricted VSDs are an immediate threat to life. They lead to profound pulmonary edema, fluid backing up into the lungs, and congestive heart failure.
Yeah.
The infant will present with pallor, heavy breathing, and critically, poor feeding and poor weight gain. In fact, the text emphasizes that poor weight gain might be the only initial feature you see.
Which makes devastating sense. The baby is burning thousands of calories just trying to breathe and force their failing heart to pump. They're running a marathon in their crib just to survive. They have zero energy left to actually grow.
Absolutely. The ECG for a VSD will show evidence of left ventricular hypertrophy from moderate shunts because that chamber is doing all the extra work. For large shunts, you see biventricular hypertrophy.
Interestingly, the text notes that inlet VSDs uniquely show a left-axis deviation on an ECG. Chest x-rays show the same cardiomegaly and engorged lungs we saw in large ASDs.
Management of a large VSD is urgent. You cannot wait years like you can with an ASD. The sheer pressure hitting the lungs is too high.
Right.
The text states surgical closure must occur between 6 to 9 months of age. If you wait longer, you invite that irreversible pulmonary vascular disease, and the shunt will flip to Eisenmenger syndrome much faster than an ASD would.
Okay, the next acyanotic lesion brings us right back to our plumbing bypass analogy. Patent ductus arteriosus, or PDA.
TDA.
The ductus arteriosus is that normal fetal blood vessel connecting the pulmonary artery directly to the aorta, bypassing the lungs entirely. It's supposed to clamp shut naturally right after birth. When it fails to do so, you're left with a PDA.
Right.
The incidence is 1 in 2,500 to 5,000 live births, making up about 9 to 12% of CHD. But the text highlights two specific populations where this incidence rate absolutely skyrockets.
Yes. First, preterm babies. They have a massive incidence rate of 8 in 1,000 live births. Their physiology is simply too immature. The muscular tissue of the ductus hasn't developed the capacity to respond to the signals to close.
Makes sense.
The second population is even more fascinating from a physiological standpoint. Babies born at high altitudes. The text states the incidence of PDA is more than 30 times higher at high altitudes compared to sea level.
30 times.
Yeah.
That is a staggering environmental impact. And the text explains exactly why. For that fetal duct to close, it requires a chemical trigger. That triggers oxygen.
Right.
When a baby is born at sea level and takes its first breath, the sudden massive rush of highly oxygenated blood from the newly inflated lungs hits the tissue of the ductus and chemically signals it to constrict and seal.
Yes.
But at high altitudes, the air is thinner. The oxygen tension in the blood is significantly lower. That vital chemical trigger is dangerously muted and the duct remains wide open.
It is a profound example of how the external environment directly dictates internal anatomical transitions. With a PDA, you have a massive connection between the two main arteries. The aorta is under systemic high pressure, while the pulmonary artery is low pressure.
Okay.
So, blood continuously shoots from the aorta backward into the pulmonary artery. Therefore, the pulmonary artery, the left atrium, and the left ventricle all become massively overloaded with recirculating blood.
Clinically, a large PDA presents with a visible left ventricular heave and a very specific type of pulse. The text calls it a bounding peripheral pulse, caused by a wide pulse pressure.
Bounding pulse, right.
The blood is rushing out to the body, but then instantly escaping back into the lungs, causing the pressure in the arteries to aggressively spike and then instantly collapse with every single beat.
And the acoustic signature of a PDA is famous. It is a continuous murmur, meaning you hear it loudly during both the squeeze and the relaxation of the heart.
Like machinery.
Exactly. The text describes it as a machinery murmur, best heard in the left infraclavicular area, right under the collarbone.
Though the text does provide a caveat. In preterm infants and newborns, the pressure difference hasn't fully maximized yet, so you might only hear a systolic murmur initially.
Good point.
The text also offers a great clinical pearl for diagnosticians. If you hear a continuous murmur at the upper sternal edge, you shouldn't just assume it is a PDA. The differential diagnosis must include an arteriovenous fistula, an abnormal connection between an artery and a vein, or a benign venous hum.
Right. So to fix a PDA, the text dictates that if it persists beyond 4 months of age, it should be closed to prevent complications. But for premature infants, surgery is incredibly risky.
So what do they do?
We use drugs, Pharmacologic closure, the text specifically lists indomethacin, ibuprofen, and paracetamol.
Wait, how do common painkillers close a hole in the heart?
It's all about manipulating the chemistry. Those drugs belong to a class that inhibits the production of prostaglandins.
Prostaglandins.
Right. Prostaglandins are the specific chemicals that actively keep the ductus relaxed and open while the baby is in the womb. By giving these drugs, you block the prostaglandins, chemically encouraging the muscular wall of the ductus to forcefully clamp shut.
That's music.
If the drugs fail, the defect can be closed mechanically with an umbrella-like device deployed via a catheter, or a surgeon can go in and surgically ligate it, literally tie the vessel off with a suture.
And if a PDA is completely ignored, the turbulent blood flow can lead to calcifications, aneurysms, heart failure, and eventually irreversible pulmonary vascular disease.
Exactly.
The final acyanotic lesion in this section is the atrioventricular septal defect, or AVSD, sometimes called an AV canal defect.
Right.
The overall incidence is lower here, about 0.19 per 1,000 live births, representing 4 to 5% of CHD. But there is a massive defining clinical correlation that the text highlights. AVSDs are seen in 40% of all patients born with Down syndrome.
It is a hallmark defect of that genetic condition. An AVSD arises from a fundamental failure in the development of the endocardial cushions.
The endocardial cushions.
Yeah, imagine the very center point of the heart, the crosshairs where the vertical wall separating the left and right sides meets the horizontal line of the atrioventricular valves. The endocardial cushions form that central crux. If they fail to fuse properly, the entire center of the heart is left wide open.
The text outlines 3 major anatomical variations of an AVSD. First is the incomplete or partial type. This consists of an ostium primum ASD, so a hole low down between the atria, a cleft or split in the mitral valve, and a defect in the AV septum itself.
Yeah.
The text notes this specific anatomical setup can give rise to a rare and complex hemodynamic phenomenon called a left ventricle to right atrium shunt, which is known clinically as the Gerbaud reflex.
Gerbaud reflex.
Yeah, blood shoots from the high-pressure lower left chamber directly diagonally into the low-pressure upper right chamber.
Second is the complete AVSD. This is anatomically devastating. There's a complete absence of the lower portion of the atrial wall and a complete absence of the upper portion of the ventricular wall.
Just wide open.
Exactly. Instead of a mitral and a tricuspid valve, the heart essentially just has one giant, common, malformed valve floating right in the middle of a massive central cavern.
The third variation is the intermediate type, which has the ostium primum ASD and a restrictive hole between the ventricles. But crucially, it manages to maintain 2 distinctly separate valve rings.
Clinically, because of the massive mixing and overloading, an AVSD presents very much like a large VSD. You see profound signs of heart failure early on.
Right.
The ECG provides a unique clue. It will show a left or superior electrical axis, along with ventricular hypertrophy. An echocardiogram is diagnostic here. The ultrasound will vividly show the 2 holes and the malformed state of the central valves.
And regarding management, the timeline is fiercely accelerated. Because the volume overload is so massive, hitting both the upper and lower chambers simultaneously, the sheer pressure destroying the lungs is immense. The risk of developing irreversible pulmonary vascular disease is extraordinarily high. Therefore, the text strictly dictates that an AVSD must be surgically repaired very early, definitively, before 6 months of life.
Right.
Okay, so we've thoroughly covered the holes and the overflow problems. But what happens when the blood can't get to the lungs at all? How does a doctor even spot that in a newborn?
That brings us to cyanosis.
We are now looking at cyanotic congenital heart disease, which is characterized by right-to-left shunts. Unoxygenated blue blood is bypassing the lungs entirely and being pumped straight out to the body.
The clinical definition of cyanosis provided in the text is mathematically precise. It is officially present when the level of deoxygenated hemoglobin in the blood exceeds 5 grams per deciliter.
5 grams per deciliter.
Yeah. Clinically, this manifests as a distinct bluish discoloration of the skin and, most reliably, the mucous membranes like the lips and the inside of the mouth.
The text divides cyanosis into 2 types, peripheral and central. Peripheral cyanosis is common and usually benign. It's due to poor local blood flow. If your hands get extremely cold in the snow, your fingertips turn blue. That is peripheral.
Right.
But children with cyanotic CHD always present with central cyanosis. The core blood supply leaving the heart itself is completely devoid of sufficient oxygen. However, the text makes it clear that not all central cyanosis is caused by a broken heart.
Correct. A blue baby in the delivery room presents a massive diagnostic puzzle. The text lists 3 main categories of causes. First, cardiac disease, which is our focus today.
Right.
Second, respiratory disease. Conditions like respiratory distress syndrome, severe bronchial pneumonia, or meconium aspiration syndrome. The heart's plumbing is perfectly fine, but the lungs themselves are failing to transfer oxygen into the blood.
And the third?
Third is central nervous system diseases. This is anything that depresses the brain's drive to breathe. This includes maternal opiate poisoning or babies born to mothers suffering from drug addiction. The brain simply isn't sending the signal to inflate the lungs.
So if you are the doctor standing over a blue baby, how do you quickly and definitively tell if it's the lungs failing or the heart's plumbing failing?
A hyperoxia test.
Yes. The text gives us this brilliantly simple diagnostic tool. You place the infant on 100% pure oxygen for 5 to 10 minutes.
This is a test of pure mechanical logic. If the underlying issue is respiratory, say the baby has pneumonia, the lungs are inflamed and struggling, but the structural plumbing of the heart is intact.
Okay.
Blood is still traveling to the lungs. By flooding the alveoli with 100% pure oxygen, you overwhelm the respiratory disease process through sheer concentration. The oxygen forces its way into the blood.
Right.
If you draw an arterial blood gas and the partial pressure of oxygen, the PaO2, rises above 150 millimeters of mercury, you have your answer. It is a pulmonary cause. The cyanosis will physically improve before your eyes.
But if it is a cardiac structural issue?
If the infant has a cardiac right-to-left shunt, the physical plumbing is bypassing the lungs entirely. The blood is taking a detour through a hole in the heart straight to the aorta.
So it doesn't matter.
Exactly. Doesn't matter if you blow 1,000% oxygen into those lungs. The deoxygenated blood is physically avoiding the area where the oxygen is located. So if there is absolutely no improvement in the cyanosis and the PaO2 stays critically low despite the oxygen mask, you have definitively confirmed a structural cardiac defect.
It is such an elegant process of elimination. If the plumbing bypasses the lungs, blowing oxygen into the lungs does nothing.
Right.
Once a cardiac cause is confirmed, the text classifies these cyanotic lesions into a few different categories to help organize the pathology.
First, they're classified by pulmonary blood flow. You have cyanotic lesions that paradoxically present with increased pulmonary blood flow. Yeah. Examples include detransposition of the great arteries, TAPVR, truncus arteriosus, and hypoplastic left heart syndrome. We'll explore exactly how a heart can be turning blue while simultaneously flooding the lungs with blood in a moment.
Okay.
Then you have lesions associated with decreased pulmonary blood flow. In these, the blood is being actively obstructed from reaching the lungs. Examples are Tetralogy of Fallot, pulmonary atresia, tricuspid atresia, and Ebstein's anomaly.
The text also provides an anatomical classification. Right heart obstructive lesions like tricuspid atresia or TOF, where the blockage is on the right side. Left heart obstructive lesions like coarctation of the aorta or hypoplastic left heart, where the systemic pump fails. And mixing lesions like TAPVR, where the red and blue blood dump into the same chamber.
Right. The reason for these multiple overlapping classifications is that similar morphological defects can behave in radically different ways depending on their severity and how they interact with other minor anomalies.
The classifications give the surgeon a roadmap. Let's look at how these different anatomical failures play out in reality, starting with the most common cyanotic defect you will see in a newborn.
Okay.
That brings us to the anomaly of parallel circuits and anomalous returns. We are looking at detransposition of the great arteries, or DTGA.
DTGA.
The incidence is 1 in 5,000 live births, representing 3.8% of all congenital cardiac defects. The text notes it is particularly common in infants born to diabetic mothers, and the male-to-female ratio is heavily skewed at 3.1.
Let's visualize the anatomy. Normally, the aorta arises from the left ventricle and the pulmonary artery from the right. In DTGA, the connections are perfectly swapped. The aorta arises from the right ventricle and the pulmonary artery arises from the left ventricle. Furthermore, the spatial orientation is twisted. Anatomically, in a normal heart, the aorta arises to the right and posterior, meaning behind, the pulmonary artery. In DTGA, it arises to the right but sits anterior in front of the pulmonary artery. This swapped connection creates a terrifying physiological scenario. The systemic and pulmonary circulations are suddenly running in completely closed parallel circuits.
If you are listening to this, hold up both your hands. Imagine your left hand is the circuit pumping to the lungs, and your right hand is the circuit pumping to the body. In a normal heart, they pass blood back and forth.
Right.
But in DTGA, those streams never, ever cross. The right ventricle pumps blue blood out the aorta to the body. The body extracts what little oxygen is left, and the blood comes back blue to the right atrium.
Yeah.
Meanwhile, the left ventricle pumps red blood to the lungs. It gets more oxygen and comes back red to the left atrium. Blue to blue, red to red. Oxygen never physically reaches the brain. So my question is, how is this baby alive for even a single minute after birth?
It's the ultimate paradox of DTGA. For an infant with this condition to survive even 60 seconds after the umbilical cord is cut, they must possess another heart defect.
Another defect.
They absolutely require a mixing point. They need a structural flaw, an ASD, a VSD, or a patent ductus arteriosus to act as a bridge, allowing some of that highly oxygenated red blood trapped in the left-hand circuit to spill over into the right-hand circuit and get pumped out to the starving brain.
Wow.
It is the irony of all ironies. A second abnormal defect is the only mechanism keeping them alive.
That is incredible to think about. Clinically, these infants present with profound cyanosis and tachypnea, rapid bleeding, within the first few hours or days of life.
Yeah.
On a physical exam, you will feel a distinct right ventricular heave because that right ventricle is suddenly doing the heavy lifting of pumping blood to the entire high-resistance systemic body. You will hear a single, loud second heart sound.
A murmur might be present, but the text is clear. The murmur is usually just the sound of blood forcing its way through the life-saving VSD or a pulmonary stenosis. The transposition itself makes no sound.
The chest X-ray will show cardiomegaly and increased pulmonary vascular markings because the left ventricle is effortlessly flooding the low-resistance lungs.
Because of this parallel closed-loop circuit, a newborn diagnosed with DTGA is an absolute top-tier medical emergency.
Yeah.
Your immediate goal as a physician is to create or artificially maintain a mixing point. You must maintain the patency of the ductus arteriosus before it naturally closes. To achieve this, you immediately start an intravenous infusion of prostaglandin E1.
And the text provides the exact precise dosage required for PGE1, 0.05 to 0.2 micrograms per kilogram per minute.
Right.
0.05 to 0.2 micrograms per kilogram per minute. You are literally using chemistry to paralyze the ductus and force the bypass channel to stay open. But what if that tiny ductus isn't enough to mix the blood?
If the patient remains profoundly hypoxic and acidotic despite the drug, you must forcefully create a mixing point. You perform a procedure called a Rashkin atrial septostomy.
Rashkin atrial septostomy.
The cardiologist threads a catheter with a deflated balloon on the end up through a vein in the groin into the right atrium. They carefully pass it through the foramen ovale into the left atrium, inflate the balloon with fluid, and then violently yank the catheter back.
Oh, wow.
You are intentionally tearing a massive hole in the atrial septum to forcefully mix the red and blue blood.
Ripping a hole in the heart just to save it. And then, once the infant is stabilized, you move to the definitive operations.
Right.
The text lists two surgical approaches. The modern, gold standard is the Jettine procedure, also known as the arterial switch. This involves a surgeon physically cutting the aorta and the pulmonary artery off the heart and meticulously sewing them back onto their correct, normal positions.
They also have to delicately relocate the microscopic coronary arteries. This incredibly complex surgery must be performed within the first 2 weeks of life before the left ventricle forgets how to pump against high pressure. The mortality rate is impressively less than 10%.
The older method, which the text emphasizes is still critically important to understand because many adult patients are walking around with it today, is the Senning or mustard procedure, known as an atrial switch.
Right. In this era, surgeons couldn't reliably move the tiny coronary arteries, so they left the great artery swapped. Instead, they rebuilt the inside of the atria. They created a complex internal baffle, a tunnel system made of tissue, that redirected the returning blue venous blood across the heart into the left ventricle and the returning red pulmonary blood over to the right ventricle.
So the pumps are wrong, but you cross the streams of blood before they enter the pumps to correct the flow.
Precisely. But the text details severe long-term complications for patients with a Senning or mustard baffle. The synthetic tunnel can become physically obstructed over time, blocking systemic and pulmonary venous return.
Yeah.
The extensive scarring from sewing the baffle causes severe atrial arrhythmias. It can cause the tricuspid valve to fail, and inevitably it leads to right ventricular failure. The right ventricle was simply never evolutionarily designed to pump against the high pressure of the entire body for 70 years. It eventually exhausts itself and fails.
Moving to the next major mixing lesion in the text, total anomalous pulmonary venous return, or TAPVR. Normally, the four pulmonary veins carry bright red, freshly oxygenated blood from the lungs straight back to the left atrium to be pumped out. In TAPVR, these four veins completely miss the left atrium. Instead, they route themselves and connect directly into the systemic venous system.
So fully oxygenated blood returns and dumps directly into the right atrium, mixing with all the blue blood returning from the body.
There are 4 anatomical types of TAPVR, based entirely on where these rogue veins erroneously attach. Type 1 is supracardiac. The veins travel upward and attach to the superior vena cava or innominate vein.
Right.
Type 2 is cardiac. They attach directly into the right atrium itself or the coronary sinus. Type 3 is infracardiac. The veins form a common trunk that dives violently down below the diaphragm and connects into the portal vein or the inferior vena cava. And type 4 is mixed, a chaotic combination of the first 3.
Physiologically, TAPVR is divided into obstructed and non-obstructed types, and this dictates how the child presents. Let's look at non-obstructed first. If the infant has an adequate ASD, a hole in the atria, to let that massive pool of mixed red and blue blood cross over to the left side and reach the body, they will present with mild cyanosis and severe right-sided volume overload. You will find a right ventricular heave and an ejection systolic murmur.
The chest X-ray for a non-obstructed supracardiac TAPVR has a very famous, iconic radiological sign in older children, the snowman appearance.
Ah, yes, the
A
snowman.
normal heart forms the bottom round body of the snowman. The top head of the snowman is formed by the massively dilated anomalous veins, the persistent left superior vena cava, and the innominate vein bulging out above the heart because they're carrying the entire blood volume of the lungs.
But the obstructed type, which is very often the infracardiac type because the descending vein is literally being pinched and squeezed as it passes through the muscular diaphragm, is a massive medical emergency.
Right.
The text states it presents with profound pulmonary edema and severe respiratory distress. The blood is being pumped into the lungs, but the exit is pinched shut. The lungs drown in their own blood. The only treatment is immediate emergency surgical rerouting of the pulmonary veins back to their rightful place on the left atrium.
That brings us to what we can call the structural extremes. We are looking at defects that represent catastrophic failures of the core architectural blueprint very early in embryonic development.
Yeah.
First is truncus arteriosus. In early fetal development, there's supposed to be one large single tube exiting the heart. As the embryo grows, a septum spirals down this tube, cleanly splitting it into 2 separate vessels, the aorta and the pulmonary artery. In truncus arteriosus, that spiraling split simply never happens.
So you are left with a single massive great artery positioned centrally, sitting right over a massive VSD. This single chaotic pipe gives rise to the systemic circulation, the pulmonary circulation, and the coronary circulation all at the exact same time.
It constitutes about 0.7% of all congenital cardiac defects. The text meticulously outlines 4 types of truncus based on how the pulmonary vessels manage to sprout off this single pipe.
Let's visualize them functionally. Type 1. The main pulmonary artery manages to form a short trunk arising from the posterior left side of the massive truncus before splitting into left and right.
Okay.
Type 2. There is no main pulmonary artery at all. Instead, the right and left pulmonary arteries arise from 2 completely separate orifices sitting close together on the posterior aspect of the truncus.
Right.
Type 3. The left and right pulmonary arteries arise independently from the far lateral sides of the truncus. And type 4, which the text notes has undergone a modern reclassification, it is now considered a severe extreme form of pulmonary atresia with a VSD, where there is absolutely no identifiable connection between the heart and the pulmonary arteries at all. The lungs are fed by tiny collateral arteries sprouting off the descending aorta.
Clinically, these infants present with cyanosis and severe congestive heart failure because the delicate lungs are being directly fed by this massive, high-pressure systemic pipe. Blood violently floods the pulmonary bed.
Yeah.
On exam, you feel a massive right ventricular heave. You hear an ejection systolic murmur at the lower left sternal edge from blood rushing through the VSD, and you hear a very specific sound, an apical aortic ejection click, which is the sound of that single massive, often malformed truncal valve snapping open under immense pressure.
You will also feel a wide pulse pressure, a bounding pulse, because the blood escapes the arterial system so rapidly into the low-resistance lungs. Interestingly, the text notes a crucial diagnostic clue. If truncus arteriosus is associated with an interrupted aortic arch, the femoral pulses in the baby's legs may be severely decreased or entirely absent.
The ECG will show right ventricular dominance in infancy, shifting to biventricular hypertrophy as the child grows. An echocardiogram is diagnostic, clearly revealing the single large truncal vessel straddling the ventricular septum.
Right.
To fix truncus arteriosus, you must aggressively medically manage the congestive heart failure first with diuretics and digoxin. But surgical correction is non-negotiable and must happen before 3 months of age to prevent the rapid onset of irreversible pulmonary vascular obstructive disease.
And the surgery is profoundly intensive. The surgeon must close the VSD so the left ventricle pumps exclusively into the truncus, which is now the aorta. They must physically cut the pulmonary arteries off the truncus and sew the hole shut, and then they must establish a completely new artificial continuity between the right ventricle and the pulmonary arteries using a synthetic valved conduit.
From truncus, we move to perhaps the most daunting and devastating defect detailed in the text: hypoplastic left heart syndrome, or HLHS.
Yeah, this one is tough.
This is a profound structural extreme. The text lists its core components: mitral valve atresia, where the valve is completely sealed; aortic valve atresia, also sealed; an intact ventricular septum; and severe hypoplasia, meaning catastrophic underdevelopment of the left ventricle itself. If you were listening, think about what that physically means. The entire left side of the heart, the mighty muscular pump, evolutionarily designed to feed the entire human body, simply didn't build itself.
It didn't.
It is either completely absent or exists merely as a tiny, useless, pea-sized nub of tissue. The entrance door is sealed. The exit door is sealed. Untreated, this is a universally lethal malformation.
Clinically, these babies might look surprisingly okay for the first few hours, presenting with mild cyanosis and hypoperfusion, but the real horror begins when the ductus arteriosus naturally starts to close.
The bypass.
Exactly. While that fetal duct is open, the right ventricle is performing a superhuman feat. It pumps blood to the lungs, and a large portion of that blood shunts across the ductus to feed the entire body. The right ventricle is literally doing the job of both sides of the heart simultaneously.
But the exact moment the duct clamps shut.
Systemic blood flow to the body instantly drops to zero. The text emphasizes that profound signs of cardiogenic shock predominate as the ductus closes. The baby crashes.
Peripheral pulses become utterly weak or entirely absent. You might feel a massive right ventricular heave because the right side is working so desperately against the closing duct. The murmur is nondescript and not really helpful for diagnosis.
No.
But the text includes a crucial mandatory directive here. HLHS is highly associated with severe extracardiac abnormalities, most commonly involving the renal and central nervous systems.
Right.
Therefore, for any child diagnosed with this defect, a total body CT scan must be performed immediately to look for missing kidneys or severe brain malformations before subjecting the child to surgery.
The ECG initially shows right ventricular dominance, later shifting to right atrial and right ventricular hypertrophy as the chamber stretches. An echocardiogram is definitively diagnostic, showing the tiny or absent left ventricle.
The management for HLHS is a monumental ethical and surgical challenge. The text outlines 3 pathways.
Let's hear them.
The first is the Norwood procedure, which is purely palliative. It is a grueling, complex operation done in 3 separate stages over the child's first few years of life. It essentially permanently rewires the entire circulation, so the right ventricle permanently takes over systemic pumping duties, while venous blood is routed to passively drain directly into the lungs without a pump.
And the text notes the mortality rate for this staged reconstruction is devastatingly high, between 10 to 40%.
The second option is definitive, but incredibly difficult to secure: a full neonatal heart transplantation.
Right.
And the third option, tragically, is supportive expectant care. This involves providing comfort measures and acknowledging that the structural defect is simply too severe for the infant to survive. It is a profound reality to confront. Half the heart just failed to materialize from the blueprint.
It's heartbreaking. Which brings us to our final major section, Tetralogy of Fallot and the Ultimate Crisis. Tetralogy of Fallot, or TOF, is arguably the most famous cyanotic heart disease. It constitutes 4 to 8% of all congenital cardiac defects globally. And crucially, according to the Nationwide Cardiac Register explicitly referenced in the text, it is the absolute most common cyanotic congenital heart abnormality in Nigeria, making up 8% of all such cases.
Tetralogy literally means a set of 4. The text explains that it results from a single embryological error, an unequal anterior deviation of the conotruncal septum during development. This one error creates 4 distinct anatomical consequences.
Number 1, a large ventricular septal defect. Number 2, pulmonary stenosis, which is a severe narrowing of the pathway to the lungs. The text notes this narrowing can occur at the valve, below the valve, or above the valve.
Number 3, as a direct physical consequence of the right ventricle having to constantly pump against that severe pulmonary stenosis, you get right ventricular hypertrophy. The muscle becomes massively thick.
Right. And number 4, an overriding aorta, which is shifted over and sits directly above the VSD, receiving blood from both ventricles.
The clinical presentation of a child with TOF depends almost entirely on the severity of component number 2, the right ventricular outflow tract obstruction.
Yeah.
If the pulmonary stenosis is mild, a decent amount of blood can still manage to get to the lungs, and cyanosis is clinically negligible. These patients are colloquially referred to as pink titties.
Pink tits.
Right.
But if the obstruction is tight and severe, you have profound, full-blown cyanosis right from birth.
On physical exam, you will find a distinct right ventricular heave. You will hear a loud ejection systolic murmur at the mid to upper left sternal edge. And again, to translate the mechanics, that murmur is not the VSD.
No, it's not.
It is the sound of blood violently forcing its way through the tight, narrowed pulmonary tract. The tighter the narrowing, the harsher the sound.
The chest X-ray findings for TOF are iconic in medicine. You see a normal overall heart size, but decreased pulmonary vascular markings because the lungs are literally starved of blood. And the text notes that in 25% of these patients, you will see a right-sided aortic arch.
But the shape of the heart on the X-ray is the classic boot-shaped heart, or cœur en sabot. The text explicitly explains exactly what anatomical features cause this specific silhouette. It is the combination of the severe hypoplasia, or shrinking, of the main pulmonary artery segment, creating a concavity, combined with the dramatic upturning of the apex of the right ventricle due to its massive hypertrophy.
It literally looks like a curved wooden shoe resting flat on the diaphragm.
Before a child is big enough for definitive open-heart surgery, doctors sometimes need to perform palliative procedures just to get more blood to the starving lungs to keep the child alive. The text details the bleoctosic, or BT, shunts.
BT shunts.
This is a surgical anastomosis, an artificial connection made between the high-pressure systemic circulation and the low-pressure pulmonary artery.
The text mentions 2 specific types of BT shunts that have vital clinical implications for physical exams. The classical BT shunt involves a surgeon physically cutting the subclavian artery, the major artery that feeds the arm, and sewing the cut end directly into the pulmonary artery. Clinically, if a patient has had a classical BT shunt, their radial pulse on that specific arm will be entirely absent because the artery was completely rerouted to the lungs.
The more modern version is the modified BT shunt. Here, instead of sacrificing the arm's blood supply, the surgeon uses an artificial Gore-Tex tube, a conduit, to bridge a connection between the side of the subclavian artery and the pulmonary artery.
In a patient with a modified BT shunt, blood still reaches the arm, so the radial pulse remains perfectly palpable. Definitive total corrective surgery, which involves patching the VSD and slicing open and widening the narrowed pulmonary tract, is usually done electively between 3 to 12 months of life.
But the defining, terrifying clinical feature of TOF is the hypercyanotic spell, universally known as a TE spell.
TET spell.
The text notes that while any child with a cyanotic CHD can theoretically present with this, it is overwhelmingly most common in Tetralogy of Fallot. It consists of an abrupt, terrifying onset of increased cyanosis, profound hypoxemia, severe dyspnea, and intense, inconsolable agitation.
If there is no rapid medical intervention, it progresses to syncope, convulsions, and death.
The text mentions these spells frequently occur in the mornings upon waking, or after a bout of intense crying. Let's break down the exact physiology of a TET-E spell. The underlying mechanical issue is a sudden, massive increase in the right-to-left shunting of blood across the VSD, leading to a catastrophic drop in pulmonary blood flow.
But why does this happen so abruptly? It occurs due to infundibular spasms.
Infundibular spasms.
The infundibulum is the funnel-shaped muscular junction located right between the right ventricle and the pulmonary valve. For reasons that are still not entirely understood, perhaps subtle changes in sympathetic tone upon waking or the stress of crying, that specific ring of muscle suddenly spasms. It violently clamps down, physically choking off the only remaining pathway to the lungs.
The baby instantly becomes starved of oxygen. They feel they are suffocated. They naturally get intensely restless and agitated. This severe agitation triggers the release of massive amounts of catecholamines, adrenaline.
Right.
The adrenaline increases systemic vascular resistance slightly but infinitely more dangerously. It directly stimulates that infundibular muscle to spasm even harder.
It clamps down further. This causes an even greater decrease in pulmonary blood flow, leading to worse hypoxemia, more agitation, and more adrenaline. It is a rapid, deadly, self-amplifying, vicious cycle.
Because a TAT spell is such a critical, fast-moving emergency, the text provides an exact 10-step medical management protocol. If you are an ER doctor, you execute these sequentially. We must cover all of these mechanics.
Let's do it.
Step 1. Comfort the child. You must try to break the agitation cycle to stop the adrenaline release. You instruct the mother to hold and soothe the infant.
Step 2. Immediately place the child in a knee-chest position.
I want to zero in on step 2. Imagine the scene. You have a child in a massive cardiac crisis. Their oxygen levels are plummeting toward fatal numbers, and the medical text says the second thing you do is physically squish their knees tightly up against their chest. How on earth does changing a baby's leg posture fix a muscular spasm inside their heart?
It is a brilliant manipulation of fluid dynamics and pressure gradients. When you forcibly compress the large femoral arteries in the legs by pulling the knees to the chest, you instantly and massively increase systemic vascular resistance.
Okay.
You are physically creating a high-pressure blockade in the lower half of the body. This sudden, massive spike in arterial pressure immediately backs up into the aorta and down into the left side of the heart. The pressure in the left ventricle suddenly spikes much higher than the pressure in the spasming right ventricle.
And because there is a VSD, a massive hole between those two ventricles, that pressure gradient instantly shifts. The deadly right-to-left shunt suddenly reverses. It becomes a left-to-right shunt.
Exactly.
The sheer high pressure on the left side forces blood back across the hole and literally rams it up against the spasming pulmonary tract, hydraulically forcing blood through the stricture so it can get to the lungs. It is a mechanical override of the heart using the patient's own legs.
It is stunningly effective. If that doesn't break the spell, you move to step 3. Administer 100% oxygen by tight face mask to maximize whatever tiny amount of blood is reaching the lungs.
Step 4. Give morphine. The text specifies the exact required dose, 0.01 to 0.1 milligrams per kilogram, given subcutaneously.
Right. This is not primarily for pain. Morphine actively suppresses the respiratory center to stop hyperventilation, and crucially, it heavily sedates and calms the patient, chemically breaking that deadly catecholamine cycle.
Step 5. Give rapid IV fluids. You are providing volume expansion to increase the shear fluid pressure in the right ventricle, trying to physically push the spasm open with fluid volume.
Step 6. Treat the rapidly mounting acidosis with NaHCO3, sodium bicarbonate. Severe lack of oxygen creates lactic acid. Acidosis makes the heart muscle function poorly and respond weakly to drugs, so you must chemically neutralize the pH of the blood.
Step 7. Systemic vascular resistance can also be increased chemically. You augment what you did mechanically with the knee-chest position by administering a vasoconstricting drug called phenylephrine, driving left-sided pressure even higher.
Step 8. If the spasm persists, administer propranolol at exactly 0.1 milligrams per kilogram. Propranolol is a potent beta blocker. It directly antagonizes the adrenaline receptors on the heart muscle, forcing the spasming infundibulum to chemically relax and dilate.
If all of that pharmacology fails, you reach step 9. Administer general anesthesia. You completely paralyze and sedate the central nervous system to drop oxygen demand to absolute baseline 0.
And finally, if there is still no improvement and the child is dying, step 10, emergency, immediate surgery. You rush them to the OR to physically cut the obstruction open or place an emergency BT shunt.
Those 10 steps are a perfect high-stakes distillation of everything we've talked about today. It is anatomy, blood chemistry, raw fluid dynamics, and precise pharmacology, all colliding in a matter of minutes to save a human life.
It really is.
What an immense, overwhelming journey we have been on today. We started with the mathematical probabilities of genetic inheritance and the threshold of disease. We mapped out an entirely new grammatical language just to accurately describe the heart's architecture.
We tracked the slow, devastating consequences of simple holes and overflows in acyanotic lesions.
And finally ended with the high stakes, adrenaline-fueled interventions required when the very blueprint of the heart goes fundamentally awry and turns a child blue.
It is a tremendous amount of information, but if I can leave you with one final reflection drawn directly from the underlying mechanics of these texts, it is the profound, almost eerie perfection of the fetal parallel circulation.
The bypasses.
Yeah, it is a biological miracle that is so devastatingly effective, so perfectly engineered, that it can entirely mask fatal, catastrophic structural failures for 9 entire months.
It is deeply profound to think about. The baby grows, develops, and even thrives, entirely protected and sustained by those temporary bypasses. And we are left to ponder the extreme fragility of that transition. How the very act of being born, of leaving the safety of the womb and taking that first vital gasp of air to close those bypasses, is the exact mechanical trigger that violently unveils the genetic hand a child has been dealt. You expect that first breath to be the triumphant start of life. But for these infants, it is the exact moment the origami unfolds, the illusion drops, and the true complexity of their survival begins. Thank you for joining us on this deep dive. I guarantee the next time you hear a heartbeat, you won't just hear a pump. You'll be picturing the plumbing.